Next, we will move to Professor Olfa Jaidane from Tunisia. She is a professor of surgical oncology at Salah Aziza Cancer Center, and she will present the fertility sparing options in epithelial ovarian cancer.
Me, and I would like to thank the organizing committee for inviting me, and I am really honored to be part of the Tunisian delegation in this Congress. So I was told to speak about fertility sparing options in epithelial ovarian cancer. Why? Because there is an increased number of affected patients who are of childbearing age with a desire of family. And in fact, 12% of ovarian cancer are diagnosed in women under 40 years with an excellent survival rate. So owing to increasing survival, there is a new focus on the quality of life, including desire of procreation. On the other hand, there is a negative psychological impact of tumor treatment. So, the American Society of Clinical Oncology recommends, since 2013, preserving fertility when treating gynecological tumors in young women. So, concerning epithelial ovarian cancer, what options do we have to preserve the fertility in young patients, and in which category of patients can these options be applied? We will try to answer these two questions throughout this presentation. As a surgeon, I must begin with the fertility-sparing surgery. It is defined by unilateral salpingo-oophorectomy and complete surgical staging. And the first large series was published 5 decades ago. And since then, different publications, initially mixing different subtypes and more recently specifically dedicated to epithelial ovarian cancer, have been reported. And the first international recommendations were published 10 years ago concerning the indication and the modalities of fertility-sparing surgery in epithelial ovarian cancer. However, many questions continue to fuel debate and remain unclear concerning this management. These questions are about oncological outcomes and fertility issues. Let's begin with the oncologic outcomes. We all know that the selection criteria in these studies are based on recurrence prognostic factors. And in the series comparing conservative to conventional treatment, patients selected for fertility-sparing surgery tend to have a better prognosis than those treating according to the standard of care. And comparing recurrence and survival rates between these two groups would lead to a potential bias, and these studies may be unreliable statistically. This is why I will present the few and largest series that have been published in this concern. This is a paper evaluating overall survival in stage 1 epithelial ovarian cancer, and as you see, the survival curves did not differ between women who underwent fertility-sparing surgery and propensity-matched women in the control group. The second paper reviewed two American registries, the SEER and the NCDP, and compared more than 2,200 fertility-sparing surgery to standard of care. And in the conclusion, there is no difference in overall survival between the two groups in the two registries. This is the latest meta-analysis, including 8 studies with more than 2,200 patients undergoing fertility-sparing surgery. And as you see, there were no difference between the two groups in overall survival, neither in disease-free survival. So, fertility-sparing surgery seems to be oncologically safe, but let's focus on the high-risk group, meaning grade 3, stage 1C, and some high-risk histological subtypes, and you will see that the studies are really contradictory. Let's talk first about the impact of grade. The last paper of the SEER showed that there is no difference between grade 1 and grade 2 in FIGO stage 1A, but grade 3 was statistically different from grade 2. In this review of Pennsylvania, including more than 1,000 stage 1 patients having fertility-sparing surgery, and grade 3 was statistically different in stage 1A and in stage 1C. But in the meta-analysis, grade 3 does not influence neither the overall survival nor the disease-free survival. And the same thing in the Crafton review. In the two registries, the curves were similar, whatever the grade and whatever the stage. So maybe because the results are contradictory, because tumors with grade 3 are less likely to be included in the different series, and this leads maybe to that question about grade 3 will not be answered. Let's talk now about the impact of stage 1C. In the Pennsylvania review, it was significantly different from stage 1A, and in the C review also FIGO 1C was statistically different from FIGO 1A grade 2, but in the meta-analysis, stage 1C does not influence the DFS or the OS. However, the recurrence rate for stage 1C grade 3 was found to be higher than the stage 1C grade 1 and grade 2. Let's focus now on the new stage 1C according to FIGO classification 2014. There are few series reporting detailed data about 1C stage according to the new classification, and in the Pennsylvania review, they collected only 30 recurrences, and they concluded that there is a higher recurrence rate for the stage 1C and 2 comparing to 1C 1. So we cannot conclude about grade, we cannot conclude about 1C stage. Let's see what is about aggressive subtypes. It is important to note that the fertility-sparing surgery was carried out in younger women in all included studies, while radical surgery was predominantly carried out in older female. And younger age has been associated with higher incidence of low-grade tumor with better biological behavior. The hottest topic in terms of histological subtypes for fertility-sparing surgery is the case of clear cell carcinoma, which occurs more frequently in younger women at early stage. However, in all the series, the number of patients studied is too small to detect a possible statistical difference between the two treatments. But I found out two retrospective studies focusing on fertility-sparing surgery and clear cell carcinoma. The first one had included only 16 patients with clear cell carcinoma having fertility-sparing surgery, and the curves of survival did not differ from the three groups. The second one included only 22 fertility-sparing surgery with clear cell carcinoma. As you see, the curves are also identical for overall and disease-free survival. But in this paper, we have noted that the mean recurrence time is too short, only 19 months for the fertility-sparing surgery group. So maybe in this group of clear cell carcinoma, we may delay the attempt of a potential pregnancy for 2 years after fertility-sparing surgery. So our questions in this high-risk group is still unsolved, and maybe there is a clue that can help us to answer our question, and this clue is the site of recurrence. In fact, in general, for stage 1A, the recurrence risk on the remaining ovary is up to 13%. And we have noticed all over the studies that in high-risk groups, the recurrences are more often extra-ovarian. So it is unclear whether such recurrences are related to the natural history of the disease or to the use of fertility-sparing surgery itself. So how we can solve these uncertain situations? It can only be solved by a prospective randomized trial, but there is only one non-randomized trial ongoing now in Japan, and including high-risk disease, I mean stage 1C or stage 1A clear cell carcinoma, and we hope that this study will provide us with more robust data in the future. So let's now talk about fertility issues. Informations in the literature are scarce, and in this review, from the 42% of women who wish to be pregnant after fertility-sparing surgery, 67% achieved pregnancy. And in this retrospective survey, we have the same rate of pregnancy, 68% achieved pregnancy. But it's important to note in this paper that chemotherapy exposure was not associated with an increased risk of infertility, and this offers me a slight transition to the next part of my presentation, which is the fertility preservation options. We all know that not only surgery had an impact on fertility in women with ovarian cancer, there is also a harmful effect of chemotherapy. Chemotherapy is now indicated in early stage ovarian cancer after the conclusion of two randomized controlled trials, the ACTION and the ICON-1, which had demonstrated the beneficial of chemotherapy in early stage ovarian cancer, and the ESMO added the indication of adjuvant chemotherapy for high-risk group early-stage ovarian cancer. And chemotherapy has effects on ovarian function, such as reproductive toxicity. The most effective chemotherapy regimen in ovarian epithelial cancer is a combination of platinum and taxane, and alkylating agents are gonadotoxic and have most consistently been associated with ovarian failure in a dose-dependent manner. So we have two techniques that can be available for a patient who will undergo chemotherapy. The first one is the oocyte cryopreservation, and the oocyte could be acquired during the unilateral ovariectomy, but we all must keep in mind that controlled ovarian hyperstimulation is contraindicated in this population. The second technique is the ovarian tissue cryopreservation, and the ovarian tissue is removed from the remaining ovary and cryoconserved for future usage. The future strategy concerned the fertoprotective agent, especially the gonadotropin-releasing hormone antagonist or agonist, which showed an impact of this strategy in breast cancer patients with a significant reduction of the risk of treatment-induced premature ovarian failure. But it is necessary to test this agent in preservation of ovarian reserve for ovarian cancer patients. And now let me conclude with the recommendations. For the ESMO, the fertility-sparing surgery is recommended for any stage 1A histotype or 1C1, 1C2 with favorable histology. For the ESGO, the fertility-sparing surgery is recommended with C-level recommendation in only stage 1 or 1C1 favorable histology subtypes. The NCCN is more take more precaution. It's only indicated for 1A. Some patients for 1C, but it is not recommended for clear cell carcinoma. So fertility sparing in epithelial cancer is still a debatable question for early stage high risk ovarian cancer. This concerns less than 5% of ovarian cancer patients, and I will make a proposal for our MEMAGO region. Maybe we can collect our data and maybe also use the artificial intelligence and develop a deep learning machine program and create the best indication for fertility sparing surgery in our region. I make this proposal and let you think. Thank you.